Price Jackson is our next speaker, and Price is a medical physicist extraordinaire. I told him I wouldn't tell a suit joke, but I can't help myself. He's gone casual as opposed to the last ProsTIC meeting, and he didn't tell me. Price, tell us all about medical physicists.
Okay, well, I hope you've got a good 45 minutes. Is that all right? To do some integral equations. So I'm the medical physicist for our nuclear medicine therapy program, and I'll be talking a little bit about how we do dosimetry in our lutetium treatments, and also where things can go as we look a little bit toward the future. Of course, what we're relying on in our lutetium treatments is our ability to concentrate radiation delivery at the cellular level. So just like any systemic treatment, we're able to target the molecular expression of cancer cells. But in this case, we also get some gamma emissions, so we can do a SPECT CT of a patient and start to query the concentration of tracer in the patient at a specific time point. That allows us to start piecing together the change in radiation dose rate with time. So when we want to do a dose analysis, like we would do with some of our clinical trials, or sometimes patients that are sort of borderline to receive more treatment, we'll do a sequence of either 2 or 3 scans in the first 4 days after they receive their administration. So that allows us to track how long the tracer goes into specific tissues, and whether it's sort of staying there with a long biological half-time. If you're going to do the dose calculation, it always follows these sort of similar set of steps where we first fuse those images in space. We're using a deformable registration algorithm, and we want to do this all basically in the image space, so the computers can do this without needing too much manual work. But you can just as easily contour each of these scans as a region of interest, and then from there work out the pharmacokinetics. So that means fitting what you call time activity curves, so tracking how long the tracer stays there, and the area under each of these curves tells you how much radiation was released in any of those locations. So again, if you do this at the voxel level, or if you do it in the whole organ space, you should get more or less the same number, because it's all basically just a mathematical operation. So from there, you can use some radiation transport approximation. Basically, you can convert this into a map of absorbed dose in gray at the tissue level. So from our process, we would get 3 scans. We turn it to the computer to run for, say, 20 minutes, and what we get out the end is a 3D dose map that the doctors can contour on their imaging system. And we are one of a number of places that are doing much the same thing, either in research capacity, and now more and more we're seeing commercial products that can do this as well. And one good news is that if we look at the methods that get applied, so Society of Nuclear Medicine put together a challenge data set and said, everyone, we're going to provide you the same data and see if you get the same numbers at the other end. And it turns out if you're doing sort of SPECT dosimetry or SPECT and a combination of SPECT and planar, and given the same contours, so taking that sort of uncertainty out of the equation, that people get very much the same numbers. So using that same SPECT-based dosimetry and the same contours, regardless of how you do the maths, which makes sense, you should get about the same number. And that's good, because that means that we're starting to get where we're standardizing this process, and we can start to consider how we combine data across different institutions. So there's recommendations from the European Association of Nuclear Medicine and MERD committees on how we do select the time points for post-therapy imaging and do our SPECT camera calibration. And the nice thing is that's feeding into how people do practice and also how the vendors bring it in and make products. And that's really going to be the driver for this being taken up in the larger scale. So we can start to understand radiobiology, but we're doing this sort of piecewise, like 30 or 40 patients at a time. But now we've got the computer technology that we can do it at larger volume, assuming that we've got things like serial imaging, or we make some assumptions about the pharmacokinetics in our routine patient cohort. Well, if we look at radiation therapy, they've got a bit of a head start on us. So first LINAC was put in like the 1960s, and then they got to computerized 3D radiation dose planning in the 90s. And we're kind of just getting there here about 30 years later. So I know if we go back, radioiodine therapy predates it all, so nuclear medicine actually is a little bit better. But we do have, in terms of looking at our dose response data, we're we're only getting to where we can match that precision quite more recently. So I wouldn't be discouraged by that. I think in some ways we've seen a lot of improvements in understanding and optimization of external beam radiotherapy in that time, and I think we can look forward to some of that, those same improvements in the next, hopefully less than 30 years in nuclear medicine treatments. If we start looking at institutional data sets in terms of lutetium PSMA therapy, and as Michael alluded to, the normal organ uptake seems to be fairly consistent, regardless if you're using PSMA 617 or INT. We can kind of predict what the normal organ uptake is likely to be, but the tumor uptake tends to vary quite significantly among different populations, which is probably part of the trials, but also among the individuals in different studies. And this is also, as Michael said, likely to be driving the response in certain individuals. So we do have some rationale to say, how can we use dosimetry to better, one, select patients? I guess that's one thing, but it's telling us that we're sort of underdosing a group of patients. So the oncological risk of progression in these underdosed patients may suggest that we can accept more risk by giving them a larger prescription of lutetium to try and get the appropriate target coverage. And that's what we do in external beam radiotherapy. We prescribe radiation dose to a target dose. We don't give everyone the same number of monitor units. We dose to the target. So these are all the kind of things that need to be answered with clinical trials, and I'm not necessarily, going to be the one to do that. We need the clinicians on board, but I would say from a technical side, this is something that can all be done. The computers are there, the standardization in the dose calculation technique is there, and the overhead to do it is really just a matter of getting a couple extra scans. And you can envision perhaps getting serial imaging at a patient's first treatment cycle and then carrying over the rest of that pharmacokinetic data to their subsequent treatment. And I'll finish with a quick case study. So I said we do this in our clinical trials, but we also do this in some routine practice. So this is a patient that presented to a multidisciplinary team. He has all the hallmarks of being a good responder based on his staging PET scan, except that he had relatively low GFR, so poor kidney function at the start. And the question is, how do we safely proceed from here? So the decision was made, let's give him one cycle of lutetium therapy, but with a reduction in the prescribed activity. And we will do serial imaging and track what the radiation dose is to kidney. And then from there, we can make an informed decision about how best to proceed. So post-therapy imaging indicated good uptake of lutetium to his sites of disease, and the average dose to his kidneys was below the published data. So we could suggest that he's unlikely or less likely to have complication or toxicity to his kidneys. From there, it was decided that we could go ahead with another 3 cycles of treatment, and he had a very good PSA response as a result. So using dosimetry just as one part of the overall picture to help inform how we could optimize our treatment. So I'll just kind of wind up there. I would say that we're getting to a point where we can start to build larger retrospective data. Of course, dosimetry is just a number. We can't fully understand patients' own radiobiology, what's happening at the microscopic scale, but we can start to build a much better picture, and we can look at trying to merge sort of institutional data sets in a more meaningful way as we go ahead. And so thanks for your time. We have a couple of resources on things like image segmentation and dose processing available as well.